Please go ahead and take your seats. We're going to go ahead and get started. All right.
Well, hi and welcome back. My name is Crystal Miwa. I am the project manager for LungMAP. I've been involved with LungMAP since before it activated. So thank you and welcome. I've been asked to speak to you today by the LungMAP Site Coordinators Committee. This is a committee that is comprised of 12 members who represent all the site types from NCTN, NCORP, CCTG, academic, and minority groups. They've organized this panel today to discuss the ongoing LungMAP activities for the ORP perspective. This presentation will cover updates to LungMAP activities, management of IRAEs, and some useful tips and tricks. I do want to point out that we are having the S1400-LungMAP update meeting. This is a presentation done by the LungMAP leadership with special presentations from Dr. Wakar and Dr. Roth tomorrow at 2:30. So as part of my presentation, I'd like to give you some updates of recent revisions and how that impacts the sites here, and also just kind of some of the new sub-studies that we have and where the future of LungMAP is currently going. So as of last group meeting, we've had multiple revisions come out. So you probably have seen these. You probably see them coming out quite often. This is made possible by the version control protocol. We're able to implement revisions quicker, and they're also shorter, and they're specific to each sub-study. So this has really helped us out a lot, and I'm hoping that it also helps you out as well. We also have a couple of revisions that are currently in the works, and I hope that you will be seeing these here very soon. So with these revisions, let's see what's been going on. We've had lots of updates to the main screening protocol. These items were done with revision 12. We've updated the eligibility to include the CMET testing. This is for the new sub-study S1400K. We've also added an S1400 Gen, which is a new ancillary study that is for US-speaking patients only, and it's for US sites only. We've also updated the follow-up period to until sub-study registration or death. And then the one I think you like the most is we've updated the registration timing to calendar days and lengthening the tissue submission to 5 calendar days. So I think you really like that one. And also planned treatment length up to 10 calendar days. Also, with the new screening protocol, we've updated a lot of the monitoring plans that we have going on. We've reduced a lot of the site audits, and these are going to be based on the central monitoring and data management if you have this already going on at your site. We've also updated if you've already have a good standing with the audit team and you've shown that you know what you're doing, you won't have to have an auditor come out as often. So also with revision 12, we've had a new sub-study that's been added. This is S1400K. It's a study that we're working with AbbVie on, and we're looking at their new drug ABBV-399, and this is for patients that are positive for CMET in squamous lung cancer. This activated about 2 months ago. We've actually had really good accrual rates so far. I know last time I checked it was over 6, and we're hoping to get about 44 patients to this trial. So now that it's open, we're getting lots of questions being asked, and we do have more coming in, but some of the basic ones that we have been getting is, my site needs the investigational brochure. Where can I find it? With the investigational brochures, within the LungMAP program, these are all available through the CTSU system. You fill out the form and send it in, and they will provide you with the investigational brochure. The second item is pre-medication. The protocol does not dictate that you have to give your patient pre-medication before you dose them on the study. So we just ask you that you follow the ASCO guidelines for that. The last item is retrospective testing of the CMET assay. This is something that we are working on, and we're hoping to have it in place here soon. We're just finalizing some of the funding aspects and the logistics of working on getting the retrospective testing. And this is for patients that are currently on another sub-study that you're looking to see if they would maybe qualify for the S1400K. The other one we added is S1400-Gen. This is an ancillary study that we have added to the screening portion of the trial. So if you notice in the screening and the pre-screening consent forms, the last 2 pages kind of go over what this ancillary study is. We have been getting a lot of questions on this study, so if you do have any questions, please ask me. Some of that information is in regards to some bracketed items within the consent forms. You'll notice that it says that the survey is offered via phone or if it's offered via a web link. This was added because if the study team decides they want to switch from a phone interview to a web-based interview, that they can do that fairly easy. CRB has told us that you cannot change this information, but if you want to add some additional information to your boiler template, you're welcome to do that. The other item within the consent form is the gift card information. Patients that complete this survey receive a $20 gift card. You cannot remove this from the consent. The survey itself is being performed by Fred Hutch, and so once you have consented the patient, sent the information, faxed it in to Fred Hutch, they will be the ones that will take over the survey. After that, your responsibility is over. So we have to keep the gift card in there. It is just to kind of give the patients a little incentive to for their time and effort that they have put into answering the questions on the survey. The last item here is the physician consent. You will notice that this is located on the CTSU website. You as a site do not need to do anything with this. It is there for your reference. If the Fred Hutch group will reach out to the physician, they will consent them, and they will complete the survey with them. So you have no obligation to do anything with this. And S1400A was updated with revision 14 and 17. 17 obviously is not out yet, but we've been trying to clarify a lot of the TSH testing that is being performed on this study. Hopefully, I think we got it right this time, but basically this test is only going to be performed if clinically indicated every 12 weeks, and then in follow-up only if indicated. So hopefully this will lessen the burden on the patients and the sites moving forward. So with revision 15 for S1400I, you're going to start seeing a lot of these changes with all of the active studies that are currently going on. We're currently updating the active protocols with updated languages to the websites and to the websites and everything else. So some of the main items here is in section 7 for the follow-up period. Patients who enroll onto a sub-study and then progress and then go on to another sub-study still need to be followed up on the original sub-study. So we did have it to where you could stop those follow-ups, but we've had to retract that and go back to that, yes, you have to follow up on that sub-study and on follow up on the next sub-study that that patient goes on. And the other item was registration timing. We lengthened the planned treatment day to 10 calendar days. So S1400F, this is going to be with revision 16. It has not come out yet, but it should be coming out here very soon. We had to do this in response to some FDA comments, and they are concerned about patients continuing treatment after they have progressed. And so they want to make sure that that the patient is still absent of any symptoms that they may be experiencing. They still have a good performance status, and they don't have any symptomatic disease progression. So we have added this information to section 7. You will also notice that we've added a consent addendum as well. So once the patient progresses and they are would like to move on, would like to continue with that treatment because they are receiving clinical benefit, they need to make sure that they sign the new consent form. And it's just a one-pager. It just gives them a little bit of information of additional options that are out there and that they agree that they want to continue with the treatment that they're currently receiving. So what is going on with LungMAP in the future? So we have a lot, the really cool thing about LungMAP is we can adapt to the changing landscapes of what's going out there in the real world. So what leadership is wanting to do is they propose that they're gonna open up LungMAP to all histologies. They've also added a new platform, which is for IO combinations. So we are hoping that this will better serve the changing needs of the patients and be exciting for those patients that are and giving them a different option out there. So some of the upcoming items that you can expect is a new LungMAP screen, and that is the study number, LungMAP. It is a new screening protocol, and so it will include all histologies. We are looking to include PD-L1 testing, ctDNA testing, and updating the protocol in general. One item to note for this is that it will be a CIRB only. So you have some time, if you don't use the CIRB as your IRB of record, to look at switching this over. Some new sub-studies, S1400-A is going to be part of this new IO combination platform. We're going to look at Pembro and ramucirumab, and this is that first protocol for non-matched patients in this setting. The last one is S1400-L, which is the first all histologies biomarker-driven study that we're working with Clovis on, and it's going to be looking at Rocrafinib. So exciting things coming in the future, and I hope that you continue to be excited about this trial as well. And I will turn it over to Laura.
Good morning, y'all. My name is Laura Gonzalez, and I'm one of the Quality Assurance Nurse Auditors at the Operations Office in San Antonio. And I'm going to talk to y'all a little bit this morning about some of the common errors that we see when we're auditing. But first of all, I'd just like to thank everybody for all the hard work that y'all do every day, taking care of your patients and putting in the work that you do. It is, okay. So some of the common auditing problems that we see when we're on the sites, when we're auditing, has to do with regulatory, first of all. So for the sites that use the CIRB, we see consent forms that deviate from with the approved boilerplate language, and we see issues where we're unable to determine when the consent versions were implemented. So it's really important that you have some way of marking your consent forms with your implementation date. A lot of times when we talk to sites, they have the protocol version, but not necessarily the date when they implement their consent forms. And so with your boilerplate document, back to that, it needs to be protocol specific, and you need to have your annual signatory information. So make sure that if you change anything, that you update that and that we see that. And then the DTL is a new requirement. So if you're using the site authority document, site authority log document that we have in SWOG, that's fine. We just need to make sure that with 1400, which is a potential FDA registration study, that you have one that's specific to that. And then, so with patient case review, and with 1400 eligibility, we don't always see on the pathology form that the pathologist is confirming the 20% tumor cells. It's getting a lot better with that. We're not seeing as much of an issue with that, so good on y'all. Then with 1400G, they have to have achieved stable disease or a partial response or a complete response at their first disease assessment after initial first-line platinum-based chemotherapy. 1400I, they must not have received systemic treatment with corticosteroids, which is prednisone or equivalent, or other immunosuppressive medications within 14 days prior to the sub-study registration. So those are some of the things that we will see occasionally with our eligibility. And so you just want to make sure when you're reviewing eligibility for your patients that those are some of the things that you might have a second set of eyes look at for you so that you make sure that your patients are eligible. With treatment, we see a lot of times that there's failure to dose reduce per protocol. So make sure that you double check that when you're looking at that. If you have issues where you need to dose reduce, make sure that you're following the protocol. Failure to document compliance with oral drugs. Keep the drug diaries for your patients. Make sure that that's in there. Or if the patient doesn't bring back their drug diary, make sure that there's a note to file. You know, the patient's dog ate their drug diary and he didn't bring it back or whatever, something, and then some way that you've reconciled that. So that's, you know, we see that a lot. And then the adverse events, we're not seeing complete reporting of adverse events for the patient, so make sure that you look at the CRF guidelines on page 27 to get all of the adverse events that need to be reported. And then for data entry errors, look at the data submission guidelines under other study materials, the CRA workbench, the ORP manual. So current date of staging is something that we don't always see. The T&M staging, we don't always see that. The number of prior systemic treatments for stage 4, the date on the uploaded reports, make sure you get that right, the measured creatinine clearance, and the RESIST data. Okay, so target lesions for disease assessment, you choose up to 2 lesions per organ and 5 lesions total. For lymph nodes, you record the smallest diameter on the short axis, but it has to be greater than 1.5 centimeters to be a measurable lesion, and nodules are not generally considered lymph nodes, or generally not considered lymph nodes, sorry. So for your non-target lesions, sorry, I know this is really busy. So you want to make sure that the measurable lesions that were not selected as target lesions, small lesions are less than 1.0 centimeter or pathologic lymph nodes with greater than 1.0 centimeters to less than 1.5 centimeters on the short axis. Bone lesions, leptomeningeal disease, ascites, pleural or pericardial effusions, lymphangitis cutis, pulmonis, inflammatory breast disease, abdominal masses not followed by CT or MRI, and previously radiated lesions that have not progressed. Those are all considered non-target lesions. Okay, data delinquency and failure to collect specimens. Again, I know this is a really busy slide, so I'll just let you take a minute to look at what you need to submit electronically in RAVE and Triad, and then SWOG specimen tracking system. And I was thinking this morning when Rodney was speaking and last night with Phyllis, if a specimen cannot be collected for whatever reason, please document that, okay? Because that, you know, we need to know if there's a reason why it can't be collected, okay? So just put a note to file or whatever. So then we're going to talk a little bit about adverse events because that's critical to patient safety and data integrity. So we're going to talk about what constitutes an adverse event, the elements required to document AEs, and how to distinguish between AEs and IRAEs. But I'm not going to talk a whole lot about that because that's going to come up later. So there's multiple clinical terms that have been used to convey an adverse event that includes the toxicity, the side effect, acute or late event, a complication, all essentially pointing to a change possibly caused by the treatment. And all of these terms imply that an intervention caused the event, which is the definition of an AE. So an adverse event is any untoward medical occurrence associated with the use of a drug in humans, whether or not considered drug-related. And then an immune-related AE is a side effect due to the immune system activation by the CTLA-4 blockade. But one of my colleagues is going to talk a little bit more about that. So what do we see commonly when we're auditing? We see the reporting of baseline toxicities, which you don't need to do, and then the failure to report adverse events. So do not report a condition existing prior to registration, and this is anything that occurs up to the time of the first infusion. We don't need to know it. But if a baseline toxicity resolves and then reoccurs, you need to report it. If it increases, you report it, but if it returns back to baseline, then it's not a toxicity and you don't need to report it. Okay? So, the protocol says you need to report all adverse events grades 1 through 5 unless present at baseline. So some pharm study says you can exclude the reporting of non-clinically significant AEs, but 1400 says we need to report them all. And that includes non-clinically significant laboratory value abnormalities. And those are the ones that we usually see aren't reported. So, in your progress note, you need to document that from the patient's medical record, and you want to document any workup or any treatment that's provided. So, date it began, treatment that you've provided, even if that means no treatment, if you're doing further testing, if you've dose reduced, if their study intervention was held, description of the event, and enough detail so that CTC-AE terms and grades can be assigned, the attribution of the AE, and you may need to kind of tease that out if more than one therapy or drug is given, date the AE is resolved, and its immune relationship. And then if you know, or you may not know, the CTSU website for NCI guidelines for AE start and stop dates. This is a requirement for FDA registration studies for SWOG as of 2018. So on the CTSU website, you can find this on the Resources tab under CTSU Operation Information, subfolder Guidelines and Procedures, and the document is titled CTEP Guidance for Recording Adverse Event Start and End Date in RAVE. And I'm sorry that's not on my slide, but I just got an email from my boss last night that I'm supposed to include that information, but it's got some really good examples on how to document those start and stop times. And it's really helpful. I mean, you have to do it first of all, but it's really helpful for us as auditors when we're looking at your AE logs and your AE reporting in RAVE. So then the CTC-AE is set up in a table format using the Medical Dictionary for Regulatory Activity System organ class. And so with each SOC, the AEs are listed and accompanied by descriptions of severity grades 1 through 5. So you know that you have to report everything by grades, and we expect everything grades 1 through 5 to be reported. So then you have to determine an attribution, and that's why we recommend AE logs, because we want to see that there's an attribution that's related to that AE, and we expect the investigator to do that with input from the research team. And so what do you know about the drug or the classification of the drug? Does the AE improve or disappear when the drug is stopped? If they're re-challenged, do you get the same AE at the same severity at the same time point? Is it worse? The AE worsens at baseline symptoms. Is the AE a result of the existing cancer signs or symptoms? Is the AE a result of an underlying comorbidity or a concurrent medication? I mean, these are just kind of some of the things you want to ask yourself about the attribution that when you're talking about the AE. And then this is just a documentation example. I'm not sure where I stole this from, somebody, someplace, because I shamelessly steal things and use them, as we all should, because we're all in this together. But this is what an AE log can look like, and of course we want to look to see if it's immune-related or not immune-related. And this is something that you can use, because we really like AE logs. That's one of the things that we live by when we're auditing. So I will pass it over to Louise. Thank you very much.
Hello, everyone. My name is Louise. I'm a data coordinator at the SWOG Statistics and Data Management Center in Seattle, and I work on lung and leukemia trials, but LungMAP is definitely my baby. I've been working on it for multiple years now and working with this lovely group of people. It's definitely a team effort, and I'm really happy that we have a great site coordinators committee that gives us wonderful feedback on both our forms and protocols and running the trial at the site level. And I would also be interested in all of your perspective as well. So I'm just going to talk briefly on data management and ECRF completion on the LungMAP trial. First of all, as Melissa covered in her talk this morning, the LungMAP is a potential FDA registration study, and you'll see that now on the protocol face page. So what does that mean from a data perspective? Basically, the data procedures are more or less the same as our standard SWOG studies. That was our starting point, at least. But there are increased data submission requirements, including some more detailed adverse event reporting and increased reporting of lab values. And we also do require the image submission via triad of all your scan imaging. There is also increased attention to your data entry, both by myself and the other data coordinators in Seattle, by central monitors, and then also by the lovely audit team that comes out and visits you at your site. We also sometimes have to adjust what we ask for in terms of data reporting, because we might realize that we missed something and it's really important for the analysis, or there might be a change in the medical landscape and we need more information in order to be able to react to that. So a good example of this is we did go back and ask for some retrospective data collection on which adverse events were considered to be immune-related for S1400I. So thank you to everyone who spent the time to go back and do that. I know it was probably not very fun, but we really appreciate that. So because there are more people looking at your data more often, you might also see a higher frequency of queries. And I just put some examples here of commonly queried fields, and they probably match up with the commonly audit issues as well. But the main thing I just wanted to say is that, queries are not necessarily a bad thing. They're not something to be afraid of, especially like if I'm writing queries to you, I'm trying to help you get your data as clean as possible, hopefully before the auditor shows up at your site. So don't be afraid when you see all the red on the form. It just means we want to help you out. And always feel free to get in touch with us at the Data Operations Center for help with that. Okay, now I'm going to just briefly go through some different data management resources. Instead of going through every form on LungMAP and specific issues, I just wanted to more point you towards some resources that can help you out. So these are the general resources for any SWOG trial, which I'm sure you're very familiar with, but I definitely recommend checking out the master form set for a study before you start entering the data in RAVE. That way you'll get a sense of what the questions are going to be and what the answer options are going to be. And that's always available on the protocol page, either at SWOG or CTSU. And we also have our handy-dandy SWOG reports, which Rodney discussed earlier, so I won't go into those in detail. And then, of course, CTSU has their data quality portal reports, and I know that's still fairly new, and you're probably coming across some issues or some things that don't make sense on those reports, so definitely feel free to send them my way or call me with any questions and we can get them cleared up. Now, specific to LungMAP, a great resource is your SWOG data coordinators, which is myself and my colleague Crystal, who you heard earlier talking about 1404. So this is our email address. We are on our email every weekday, most of the day. We have a very quick turnaround time on those emails, and we're really happy to help with any sort of question. We do have a quarterly email that's sent to your institution's head CRA that provides you an update of LungMAP at your site, like how many patients you have on which sub-studies. And then it also includes an expectation report that is specific for the LungMAP study and all of its sub-studies. So if you haven't seen those, ask your head CRA if they're receiving them, or send us an email at our email address and we can see if you've been getting them. And then finally, the most important resource I wanted to discuss is our RAVE data entry guidelines that we have developed for this study. And they are super helpful. Basically, anything that I could have told you today, you can find in those data guidelines. And it's also a living document, so if you notice something's missing, or there's something you always have questions about you want us to cover, definitely let us know and we can update the document. So this is an example of what it looks like. Sorry, it's a little blurry, but I mainly just wanted to show you what the layout is. So we have screenshots of the forms and then notes about different fields on the forms. And this was originally created by Rose, who's one of our LungMAP auditors. She did a really great job. So it has input from both the audit team and the data management team, as well as review by the site coordinators committee, the study statistician. So really try to get a lot of perspectives on it so we can make it as accurate as possible. And here's where you can locate the RAVE data entry guidelines. It actually lives as a chapter of the SWOG ORP manual. Down here at the very bottom, it's chapter 16E. But it's probably easier for you to access it from either the SWOG protocol page or the CTSU page. So if you're in the SWOG S1400 page, it's the first link here under Other Study Materials, Data Submission Guidelines. Or if you're in CTSU and you go to Documents and then come all the way down here to Case Report Forms, and then it's the last link there, number 5, S1400 Data Entry Guidelines. And I know the CTSU website is often changing where the documents are located, so if you're having trouble accessing them, again, just send me an email. Okay, I'm now moving on to some more specifics, but this was actually, a lot of this was covered by Melissa in her talk because we kind of unabashedly stole some of the forms changes that she did on 1605. This is basically to get our forms more in line with the CDASH guidelines for collecting data that might potentially go to the FDA. So I will just briefly skim through this. And this you will see on S1400F, S1400K, and any new sub-studies that we develop in the future. And then, of course, the older sub-studies are still using the forms that we started with some tweaks. So the first one is the eligibility criteria form. Melissa covered this. Basically, it just contains all of the different sub-study eligibility criteria from Section 5 of the protocol, and you just have to go through and electronically say yes to every question, confirming that the patient did meet all of the eligibility criteria. And then if in the future you realize that the patient was ineligible, or if I reach out to you saying I think the patient's ineligible and you agree with me, I will ask you to go back and change one of the appropriate criteria to no and put a comment in, so that way we have an electronic documentation of exactly which criteria the patient did not meet. But hopefully that will never happen. The on-study form has just a really brief change where the questions are now numbered, and if you have a comment, you just have to select what question number you have a comment on. That's just so that we can correlate the comments with a specific question. Okay. The treatment form, so for any infusion drugs, we will now be asking the volumes of the drugs, both prepared and delivered, and the infusion start and end time. So just a good thing to know so that you can prepare your source documents to collect this information as well. And another example of why I recommend looking at those paper forms before you start entering data in RAVE, so you know you might realize that we need a little more data. So the adverse event forms, this is a form I anticipate will probably be changing again soon because CTEP has been putting together a standardized form that we'll probably starting to implement on our newer sub-studies. But for now, what we've basically done is added a few additional questions. So sorry, it's a little blurry, but for any sub-studies with immuno-oncology drugs, so those are like your immune checkpoint inhibitors, we are now asking if the AE is immune-related. So for instance, S1400F has this question. And then for all of our new sub-studies, we'll also be asking if the AE was considered serious. And if it was, we want you to report the CTEP errors report ticket number. And this is really important so that we can link those SAE reports with the routine AE reporting in RAVE. Finally, I think Melissa covered this form. It looks exactly the same. So it's an end of study form just to let us know that the patient has completed all protocol required procedures, including follow-up. And so that would be submitted at the end of the protocol defined follow-up if the patient's documented as lost to follow-up per our policies, and if the patient withdrew consent, and then, of course, if the patient expired prior to reaching maximum follow-up. And this is not the same as the off-treatment notice, which is submitted when they stop the protocol therapy. That, I believe, is all I had. So next, we're going to hear from Lavinia, who is the co-chair of our Site Coordinators Committee, and we're very lucky to have her on that committee.
Good morning. Thanks for having me. My name's Lavinia. I'm from Orange County, California, from St. Joe's, and please bear with me. I got a cough this morning. It must have been that long journey, that whole hour flight that it took to get here. So we're going to review a few pragmatic components of managing the immune-related adverse events occurring on the LungMAP study and share some practical tips in reviewing examples of IRAE guidelines to utilize, also how to limit and treat IRAEs, tips when reporting adverse events and the immune-related adverse events, and also resources about IRAEs to really better understand these events. So until recently, there's really been a lack of evidence-based guidelines on how to treat immune-related adverse events. And I'm sure most of you have seen this article that came out earlier in the year. There's been case studies showing that non-oncology providers really don't have the extent of the pathophysiology knowledge of the treatments and even identifying immunotherapy as a standard oncology treatment. So, your patient shows up at the emergency department, the first thing they ask them is, when they're a cancer patient, is, oh, when was your last chemo, radiation, and when was your surgery? It's becoming more common, and some of your centers may have already adopted this, where they know to ask, are you on an immunotherapy? So this guideline came out, which then led to the ASCO joint NCCN guidelines on immunotherapy that was just released in February of this year, which we're utilizing both on protocols such as LungMAP and also for any patient on immunotherapy. I know there's regional differences. Not everyone adopts this guideline, but this is the main one that we're just highlighting today. So going in, the key really is to be aware, especially with LungMAP, is to really be aware of who these treatments are for and who they're not for, who they're appropriate for. So really paying close attention to patient and family history. S1400-F protocol, which is the anti-PD-1, PD-L1 trial, in the eligibility, really looking to fully assess, did the patient have any or any autoimmune disease or inflammatory diseases, also various thyroid issues such as Hashimoto's, and then numerous skin conditions. Do they have a loss of pigmentation? Do they have alopecia? Do they have Graves' disease or any kind of psoriasis that requires systemic treatment? And then also your primary immunodeficiencies, and this is like a group of more than 350 really rare chronic disorders where the immune system or part of the immune system doesn't work properly or is deficient. So really identifying these patients up front and finding out, do they have this in their history? It's key to identifying before they go on study instead of finding out afterwards. S1400-F, the protocol indicates there aren't any specific con medications, and it's noted in section 3 that there are no clinical reactions with other medications. However, we really need to ensure that the patient's current and past treatments meet eligibility. So absolutely no prior PD-1, PD-L1 inhibitors, no CTLA-4 inhibitors such as Ipi or tremelimumab, and then no alkaline agents such as lomustine because they inhibit the DNA repair, and there's also no anti-neoplastic agents such as mitomycin within 42 days of registration to the sub-studies. S1400K has this wonderful patient identification wallet card, and your sites may have a standard wallet card, and I'll show you an example on the next page. This one's wonderful. It says exactly what agent they're on. And then again, we give this to patients and families before they start treatment. We really educate them, keep this in your wallet, and please pull it out at any non-oncology visit. So if they end up in the emergency department or they're hospitalized, or if they're going to any specialist, dermatologist, or anyone that they're going to see, pull out your wallet card and let them know that you are on an immunotherapy and on a clinical trial. So here's an example of an immunotherapy identification wallet card that we use at St. Joe's. It's non-branded. It's standard for all of our patients on immuno-oncology. We also write on the back of this one if they're on LungMAP, but we also can utilize any protocol-specific identification wallet card. One of the barriers we've seen with using the patient identification wallet cards is when the patient presents to emergency department, the folks don't know that they need to do anything with it, so they'll just say, oh no, I don't need that card, I just need your insurance card. So then there's also a bigger push to really educate our non-oncology care team. So, our oncology care team, we're used to immunotherapies, checkpoint inhibitors, we've been using them for several years on studies, but really connecting with your non-oncology team. So we did some in-services with various departments, and I think it was the intensivist, their key feedback on our in-service was, well, treating with this high dose of steroids is counterintuitive to how I was trained. So it made us realize it's really teaching the potential adverse events with immunotherapies is all the itises, the inflammation that could occur. So it's really alerting them to those itises, not memorizing which specific itis will occur, and then really understanding that, A, you need to call the oncology care team, look up the guidelines, look up the protocol, and figure out how to treat and manage this patient appropriately. For the treatment plan, S1400-F, this is another example from that protocol. Section 7.1 also uses the ASCO guidelines for pre-medication and corticosteroids that Crystal spoke of earlier, and they can be used to manage the immune-related adverse events. And again, keep in mind it's that open communication with your non-oncology care team and really just establishing that relationship, intensivists, hospitalists, emergency care providers who are more likely to see your patients when they end up with a severe immunotherapy adverse event. And then the wallet card again, when they end up in an emergency room that's outside of your facility. Well, how are those folks to know, A, they're on a clinical trial or more so that it's immunotherapy? So here, this is just a snippet of 10 pages of this chart in protocol S1400-F under section 8, and it really just outlines the management plan of the adverse event management with prednisone and corticosteroids. And there's another section, it's not on this slide, but the general section, I think it's 8.2, really goes over that there's no dose reductions with RV-LungMAP or tremelimumab, and then that the maximum dose delay is only 28 days. Also that dose interruptions and discontinuations are allowed, and just really referring back to this chart when you do see an adverse event. And again, it's all the itises, all the itises that we're really worried about and concerned, and it's those high doses of steroids and then the proper tapering and holding of the immunotherapy that they're on. Looking at reporting, I know, Louise, you're talking about how to report these events. Just the two key things I can think of when going over this is really the causality. And sometimes even our own care team doesn't know what is the immune-related adverse event. Is it the immune-related adverse event or is it something else? Is it their baseline? Is it other medications? So really documenting that in the physician notes is just key, not just on your notes, but really have it documented in the clinic notes. And then also for the memo that we recently received, CTCAE version 5.0 will be implemented, as Louise was telling me, starting with the screening protocol for new protocols in LungMAP moving forward. And then just some wonderful resources. If you're new to LungMAP or if you just want a refresher, these are some key ones that we've used at our site. Dr. Bezenhova has a webinar from LungMAP from December. There's also an immune checkpoint inhibitor paper that came out recently. The CTCAE video is a wonderful, just explains how the immune system works and what the goal is of this kind of treatment. And then the last point there is a printable tool. It doesn't discuss the management, but it really lists the common toxicities that are associated with immunotherapy agents. So these are some common and easy to use guidelines. This is one of the ISLAC who published this immune-related adverse event guideline last year. It's really tied closely to, a lot of the information here tied closely to the NCCN guidelines, and I know some people have been using this one for LungMAP. Thank you for hanging in before lunch, and my colleague Jess, who's the chair of our committee, is going to go over some last-minute recruitment and best practices.
Hi, everyone. My name is Jess Jordan. I am from the West Haven, Connecticut Veterans Administration Hospital. I just wanted to take a little bit of your time to go over some recruitment and best practices for the LungMAP trial. So, some of the main concerns we hear from sites is when to implement and when to approach patients about the S1400 trial. So, as a committee, we have really thought over this, and the best time to come to a patient and to the providers is when you're setting up the initial care plan for the patient. So it could be when they're initially diagnosed, when they're starting platinum-based therapy. You really want to approach them with the pre-screening protocol. This pre-screening protocol allows them to have the next line of defense, and that's how you should explain it to them, that, you know, so we have this one treatment that we're going to provide you, and then if that should fail, we're not going to say, you know, when or how, but should you need something else, we can have this ready and lined up and ready to go through the pre-screening portion of this trial. So the next thing I have on here is, when should the providers be approached? So now this is very key. You want to keep the LungMAP protocol in the forefront of people's minds. I know for our site, we tend to discuss it in tumor board and team meetings. I remind them what's going on with the trial, what's currently open, and also at that time when we're discussing patients, I'm going to show you on the next slide, we have a templated note that actually says, was this patient referred for a clinical trial, or was a clinical trial discussed? And this way, it's documented from the start so that we know to go over it, and whoever sees the patient knows that this was discussed and to bring it up again later on. So how is it the best way to keep it in everyone's mind? The LungMAP team does a very good job of producing newsletters, protocol cheat sheets, the protocol cards we've already talked about. So those are key things to print out and keep giving to your physicians. Keep reminding them, show them these newsletters when you have meetings and group discussion. All right, so here is the example of the tumor board note that we use at the VA. So you'll see here, it says clinical trial availability. So here we have clinical trial availability if this patient was discussed, could potentially qualify for LungMAP. So, and then right here, next we say patient will be referred for clinical trial at this time. If we were talking more about pre-screening, we would say something to the effect of patient will be referred for clinical trial and discussion upon progression of lung cancer. And also another thing I want to point out is right here, we tend to put this ECOG performance status in here from the beginning. So when I'm signed on to one of these notes, I know from the beginning what the performance status is, so I can get an idea generally how healthy the patient is when they're being referred to us. And here I have an example of the LungMAP newsletter. So you'll see it just keeps everything in the forefront. It gives you an update of what's happened since the last newsletter. It also, if you're competitive, it gives you a little idea of who's the top recruiters, so you can try to get your name on this list in the future. So next, I wanted to go over some best practices. So as you know, and anybody who has this trial open, it's a very complex trial. It has a ton of moving parts, and it's constantly changing, as Crystal discussed in the first part. So this is a form that I use at the VA to track our protocols. So you'll see I have a description of the amendment. So here I'll just put like a brief what changed. I left this in here because we initially had started with our local IRB. So if you are using your local IRB, it's good to track when you submitted and when it was approved. And then here is, these last two columns are the most important part as far as I'm concerned. Were there changes required to the informed consent? You can put yes, no in this column, and then here is where you put the document version date, which can also be the implementation date. And Laura had discussed this before, and how we tend to track that at my site is we have this document. So you see here with the revision, what's the most recent implementation date for the form. And then on the bottom of my consent form, I always put implementation date. So you have the protocol date up in the top corner, which has the version date from the actual protocol. And then usually on the bottom left, I'll put implementation date so it can line up here and on the consent form, and that way it's easier for the auditors to come through and check, and just, it's a much quicker for them to audit in that way. So this is more, I mean, to each their own on how you want to organize your protocols, but I wanted to show you a couple of examples from my site and then Lavinia's site about how we kind of keep everything organized. So personally, I like to kind of have everything numbered out here, and then so I'll have the current protocol, which breaks down into here. So I have all the obsolete protocols here dated, And then I have all of the current protocols listed out. This way, when anybody who's not me is looking for something, they know where to go and they know which ones are the most current protocols that they should be looking at. And this here is a breakdown of how I do the amendments. So if you see here, this is my local IRB. So these are things that the documents that are submitted to my local IRB and how I keep track of them. And I usually put like a little brief, what was changed and documentation on that and what the amendment number was. And then here is how I've broken down into the CIRB documents. So once we opened the CIRB, it was on revision 9 and 10 was the first revision to go through. So if you open up these individual blocks, it has the documents that are all included for that specific revision. Now, this is how Lavinia divides it up. She brings it up a little more, like she does the training separately and the source documents and the finance documents and, you know, all of the IND safety reports. And then she breaks down the revisions in kind of the similar way that I do, like this, with each revision broken down into a separate folder and then all of the documents in that separate folder. As you can see here, it's a little more example of that with all of the consent forms and memos and CIRB applications, which it is also important that you are retaining the applications. Sometimes I feel like sites might have a little hard time with this because it is on the CTSU and you don't know necessarily to save and record, but I choose, it's a really good idea to have these applications and the approval letters and everything kept in these folders with the actual revisions. So I know Laura already kind of went over this, but this is how our site tracks adverse events. So it's very similar to what Laura has. So I have all the subject information at the top, date that the AE or SAE was reported, the description, the category, start date, end date, severity / grade, was it serious, yes or no, was it expected, key here again, was it immune related? And then I have a column where it says action taken, attribution, and then outcome. And down here I have a little key so I can fill numbers in here so it's a little easier to kind of fill out. It doesn't get junked up with a bunch of writing. And then very, very important, down here at the bottom, I have the PI signature and date. Though our site investigators are very good about documenting in their notes the grade and the attribution, I find that it's important also to have them sign off on the bottom of this because it's just a double check. Like, you know, God forbid they do miss something in their note and you don't necessarily see it. This is them confirming that they've reviewed and seen it, and this is how they are choosing to grade and attribute the event. So with that, here's a picture of our LungMAP team. So if you see any of us around, feel free to ask us questions and reach out. So I think at this point now we're going to have a little bit of a Q&A open forum. So if anybody has any questions, feel free to come up to the microphones and ask us anything about any portion of this discussion. Anybody?
I know there are LungMAP questions out there. There have to be.
There definitely are.
Don't be shy.
So I know some of the questions that I've kind of heard, and Crystal, maybe you can speak to this, is about the Foundation 1 testing and about how some sites would like to use Foundation 1 testing that they're doing on their own in cases where there's patients who don't have enough tissue but can't have another biopsy or do not want another biopsy, and so sites want to use their local Foundation 1 testing.
Can you hear me? Oh, okay. There's no light that goes on here. So yes, the study team is very, very interested in using outside FMI testing to see if a patient would qualify for one of the sub-studies. And this is actually a bigger issue than just our study. FMI is trying to reorganize their system and how they do this with tests that are being done outside clinical trials and trying to figure out a best way to kind of merge their two systems so that studies like the LungMAP can use outside testing so patients don't have to go through another biopsy. Unfortunately, I think they're slowly making progress, but it's going to be quite some time before they will be able to implement this at LungMAP or any other clinical trial.
Okay. All right, does anybody think of a question while we were talking about that? Anybody?
So Jess, I can think of another question that we got. It's regarding the new version 8 of the staging
Staging.
for lung, and how are we now enrolling patients when we're still doing version 7?
Crystal, can you speak to that? Or should we?
Do you want to do that?
I believe we're going to continue asking for staging using the 7th edition guidelines because that's what's in the protocol and we want to stay consistent. We are potentially going to ask a few additional questions that might help us then map that staging to the 8th edition staging in the future, but that is something that needs to be worked out at the statistical center. And then when we open are we switching to 8th for the new?
Not yet.
No, okay. So for now, until you hear otherwise, continue to report staging under the 7th edition staging guidelines.
And then just as a practical perspective from our site, what we're doing, I know for breast, we have an app now, and it's really good with the new breast staging, and we can do it. The coordinators sit in tumor board, and you can hear what's going on, and you just put it in, you have it. Well, I haven't looked in about 2 weeks, but I haven't seen a good one for lung. So what we're doing at our site, instead of asking them to stage out loud everybody with both stages, the ones that we're really interested in, we'll ask them at the time during tumor board, or we'll run up to their office and say, I understand they're this stage by version 8, but I also need version 7. And then when they document in their notes, we make a clear paragraph that per 7th edition of staging, this is their stage, because if you look at pathology and their clinical staging is going to be different, and I don't know if that's come up yet in auditing, but that's what we're doing at our site, and it's the onus is completely on the coordinators, all the responsibility. It's very burdensome. Our doctors don't like it. They're getting used to it. So that's what we're doing until we find a better app, and if we do find one, we'll definitely share it on the webpage.
So I also know that with the staging, sometimes there's questions about why they make us redo it at the current stage that the patient's at now, when they could be recurrent. Do we know why they request that? Because, you have your initial staging of each patient, and then there's concerns about why we're asking to be restaged at each section of the protocol when they are recurrent.
Yeah, I've basically just been told that we want to know the stage of the patient at the time of study entry. And we have patients coming on the study at different points, after different numbers of therapy, lines of therapy. So I don't have much more for you than that, but
Okay.
it's a good question.
It's Stephanie, and I had a question kind of surrounding that, and I think that's where Jessica was going with that, is because when I've had patients who've had recurrence after resection, there's not source documentation that says M1A or M1B, and the on-study CRF asks to have the patient stage at the time of study entry. So I might have had a patient who was a T3 and 0, M0, and now recurrent, and that's how they're staged in the source documentation, because the clinicians don't restage these patients. They just continue to say T3, N0, M0, recurrent. So that was kind of my question, was doing those forms correctly and having that source to indicate if the patient's M1A or M1B.
Yeah, so M staging, as long as there's some documentation of a distant met, that's basically all you need to confirm that they're at least an M1. But we do allow patients on the trial that are M0 if they're recurrent. So you won't get a query that fires or anything if you put M0. But if the patient does have distant mets, the auditors will catch that when they come around, and they'll say, you should have recorded this as either an M1A or M1B, because the patient did have distant mets at the time of registration. So I know it's a little bit of an extra burden, but we're trying to collect the staging that represents the patient's disease at the time of study entry. Do you have anything to add to that?
No, you said it.
Thank you for your question.
All right, anything else? All right, I think that's it then, and thank you guys for having us.
Thank you.
The LungMAP update meeting will be on Friday at 2:30
Yes, in Seacliff.
in Seacliff, and the full study leadership, including study chairs will be there, so definitely come with your questions and we can ask them as well.
All right, thank you very much to everyone who has spoken to us today. But if you have any questions throughout the conference, and if you see one of our speakers, please feel free to ask those questions so that you can get them answered. Just a reminder, please fill out your evaluation and be patient as you're handing it in the back. We'll have a couple of individuals out there helping to give you your SOCRA versus the nursing certificates, but we'll just need you to turn in your evaluation. So with how many individuals we have here today, if you could just please be patient. I would like to invite Mrs. Oishi to do our drawing for a stay at their vacation home. No, you can, whatever you would like to do. Thank you. Thank you very much, ladies. Thank you.